Okay, so one last talk, and we talk a lot about the future and stuff, and obviously I'm a little older than some people, so I'm not going to be here for a long time in the future, and we need to train people in the future to tackle some of these questions that we haven't taken care of ourselves. So one of the things that is nice about being at UCLA is we get lots of students who are interested in being in the lab, and so we have them come in and they basically can do one of several things. They can be an internship, just learning what goes on in a laboratory. They can also come in more actively and do their own projects. Well, at least a portion of a small project usually takes them at least 2 years to do that. So we get them to commit early on in their undergraduate or medical student career, and we get people from a neighboring Loyola Marymount University to come in as a in-student internship program. And so I asked Clare, who's the director of PHLBI, to just talk to us about that resource, and I think that's one of the more rewarding things that I have when I'm in the lab is working with the students and having them start to think problems through and actually help and see how they start to enjoy learning about science and how to do research. So, Clare. Oh, by the way, this about Clare, I kind of stole her from the Leukemia Society because she was originally working for them, and I was seeing her, and she kept telling me how hard they were working. And I said, "Well, come over to us, and we'll help you work a little bit less often." But she's worked just as hard for us.
Thank you very much, Dr. Cameron. It's really hard getting up here after all these brilliant minds today, so I'll try to make the next few minutes a little bit interesting for you. So as Dr. Cameron said, my name is Clare Cameron. I'm the Executive Director of the Pacific Heart, Lung and Blood. And today's topic is Resources for Research, the Student Internship Program. But first of all, for those who don't know who we are, the Pacific Heart, Lung and Blood Institute is a 501c3 nonprofit founded in 2002 and modeled on the National Institutes of Heart, Lung and Blood. And you can see there that we have a division for heart, for lung, and for blood. And under the Pacific Lung falls the Pacific Mesothelioma Center and the Pacific Thymus Center. We support 2 labs. We have a lab at UCLA, the Punch Lab, and a second lab on Santa Monica Boulevard. And Dr. Cameron is one of our scientific advisors. So the mission of the Pacific Heart, Lung and Blood Institute is to develop early-stage research into effective treatments for diseases of the chest. And malignant pleural mesothelioma is a disease of the chest. So just this one, I know you've had this slide up several times today, but just to say that it's brought to you by the Pacific Meso Center in conjunction with the CME Office of the Continuing Medical Education of the David Geffen School of Medicine. I'd really like to say we're so grateful to our sponsors, but we're incredibly grateful to our brilliant speakers who've come from all over the world, from Australia, from Italy, Hawaii, Florida, Maryland, and Vermont. Thank you very much indeed. And Washington, D.C., of course. Sorry, Dr. Schrum. Okay, so we're pleased this year to report that we received $1 million in a grant from an anonymous donor, and that enabled us to hire 2 world-class scientists, and they started with us last month. Masa Heidi Tony is a director of research and senior research scientist. He received his PhD at Tohoku University in Japan. His wife, Yukiko Tony, is a senior research scientist, and she received her degree at Tokyo Metropolitan University in Japan. Both scientists have worked at Cambridge University, Oxford University, UPenn, and Cedars-Sinai Medical Center. At Oxford, UPenn, and Cedars-Sinai, they worked in gene expression of FOXP3 in regulatory T cells, TREG, which play important roles in suppressing the anti-tumor immunity in cancer patients, resulting in increasing cancer cell survivability. We received $100,000 pro bono in legal fees from the law offices of Wilson, Sassoni, Goodridge, and Rosati, which enabled us to file a patent in June this year for our mesenchymal stem cell research project, and Masa and Yuki will continue with that research. So last year, we received over 250 applicants from students wanting to work in our lab, and we could only accommodate less than a dozen. So that level of demand clearly shows the students think it's worthwhile. PHLBI provides undergraduate student interns from nearby colleges, UCLA and LMU, early career training and mentorship in medical research. Our interns are given hands-on educational opportunities that are difficult to obtain at their host universities as undergraduate students. At PHLBI, our interns have the unique opportunity to gain real-world experience and fill meaningful roles in medical research at a young age. In return, PHLBI's core mission of conducting cancer research helps us meet our mission. And this program is funded in part by grants that we receive. And we received very recently a $20,000 grant from the Samuelson Foundation for our student internship program. So the students who have individual projects also help us with our tissue bank. Our tissue bank received IRB approval in 2015 with the purpose of collecting health information and tissue samples from participants who wish to donate their tissue for future research at PHLBI. And we share that tissue with UCLA. Both normal and diseased tissue samples are collected and placed into a database maintained at PHLBI. And this is where our students are a valuable asset to us, because the students assist with handling and processing human tissue, blood and urine specimens collected from patients undergoing treatment at UCLA. So the new student will initially be trained by more experienced students already working in the lab. Once the new student becomes familiar with lab protocols and have completed their safety lab training, he/she will operate with minimal supervision. The UCLA students do not get paid, but work for academic credit, the Student Research Program, or SRP. They work approximately 10 to 20 hours a week, primarily during late afternoons and early evenings, with the heaviest workloads on Mondays and Thursdays, which is when Dr. Cameron does his surgeries and there is tissue to process. They're also expected to attend our weekly research meetings, which rotate between the VA and PHLBI, and they are given the opportunity to present the projects they are working on to the group. We have 4 students from LMU who receive a stipend from a financial aid reward program. So we started this program with a very special young man called Cheng. Stephen took a gap year in his 3rd year of medical school and worked very hard for us that year. He recently graduated from the David Geffen School of Medicine at UCLA and is now a medical resident. During his time in the lab, Stephen had a major role in developing the protocols for our tissue specimen repository. The inventory of specimens are managed with the use of Corti, a free program that is easy to use, allowing access from any computer or mobile device with a connection to the internet. It allows for easy organization and storage of specimens that can be tracked between both the Punch lab and the lab at UCLA. And the program allows for one to quickly be able to sort through a vast collection of specimen types to find a particular sample of interest, and you can even track which wells the cells are in. Stephen performed a pilot research program on this existing test tube draining devices, which are utilized in nearly all hospitals today, with the goal of making novel improvements and fabricating a 3D printed prototype that may one day improve the way surgeons can more accurately monitor post-operative recovery and optimize the timing of chest tube removals. So another project Stephen led was the optimization of culturing 3-dimensional human tumor cell models to be used as an experimental test system to rapidly evaluate the effects of cryoablation to treat isolated mesothelioma nodules. This is taken from a poster that Stephen presented. The experimental studies demonstrate promising results on the potential for cryotherapy as an adjuvant modality for initial treatments, as well as treatments in cases of recurrence, with the eventual goal of developing a cryoablative device that can safely and effectively treat the large surface areas that mesothelioma often invades within the chest cavity. A while back, we provided support to Dr. Warren Grunfest at the Bioengineering Department at UCLA and his capstone students to develop a cryotherapy system designed to improve the outcomes of surgical treatment of mesothelioma. We invested in a thermal camera, which was used to improve the cryosprayer design, with the understanding on how small changes in the outlet can affect the function of the device. There are several other devices on the market, but they have neither the volume nor the control for our purposes. They're really designed for cryoablation of small tumors and not for the instant flash freezing of the pleural cavity. This device can actually freeze up to -40 just after 40 seconds. So 2 UCLA students, Michael and Karen, are working on the early stages of developing a multicellular spheroid that can effectively be used as a tumor model for subsequent stem cell immunotherapeutic experiments. In developing a multicellular spheroid, PHLBI can conduct a very high volume of experiments involving the genetic modification of stem cells in slightly different ways, which will bring us one step closer to identifying the most effective treatments. This is a novel way to screen many variations in the use of treatments, such as immunotherapy for cancers, that are virtually impossible to treat otherwise. There's so many different combinations of immunotherapy drugs, and we still don't know how to figure the best options. Applying this basic concept to a spheroid that more closely mimics the tumor environment inside of a human being, the development of a multicellular spheroid will be a cheaper, faster, and much better than doing animal testing. This could potentially add data to our mesenchymal stem cell research project, and we're very, very excited about this project because it's going to be a big one for us. And this is just the taste of the sort of things that we can achieve with this program. We have incredibly exciting projects in the pipeline for 2018, from stem cells to actively monitoring Fitbits on patients to growing multicellular cells. And here's what 3 students had to say about the program. Tania, by working in the lab with live tissue obtained from patient surgeries, I have come to understand how closely research and clinical treatments are linked. The findings obtained from an experiment in the lab can directly provide knowledge required for the development of clinical treatments, which is incredibly exciting. I find fulfillment in knowing that my daily work with cell cultures could contribute not only to the general body of scientific knowledge, but also someday to improving patients' lives. Min said, as an intern at Pacific Heart, Lung and Blood Institute, I have learned how to apply my textbook knowledge to real experiments. Under the guidance of their scientists and Dr. Cameron, I'm able to design, conduct, and analyze experiments that track cell growth and viability with the addition of different interleukins. I'm very thankful to be able to participate in research that can potentially help so many patients and their families. And Blair, working at PHLBI was my first exposure to research that has pushed me to pursue a career in academic medicine, from processing tissue specimen to growing and modifying mesenchymal stem cell lines to conducting clinical research. I've been able to see the small incremental steps necessary for answering a research question and have grown to appreciate what it takes to advance medicine by actually getting to do it. PHLBI has given me a glimpse into the challenges and rewards of advocating for patients at every step in the process of their career. And in conclusion, we're really in a unique position in helping these young undergraduate students work in a lab with human tissue. The experience may help them realize what they want to do with their careers, whether it be in the sciences, a surgeon, a doctor, a PA, or nursing. Their experience in the lab will teach them how to hone leadership and teamwork skills as they collaborate with others. They can bring fresh ideas and perspectives to our team, and they can produce publications for our lab. And importantly, the research process assists students in developing skills which they will use throughout their lives. Participating in research teaches students how to communicate with their ideas and how to analyze and critique the work of others. Thank you.
Any comments? Dr. Tania. Correct. Yeah. No, I mean that's been a problem all along in the days in the past when even histochemical stains weren't very well developed, people would die from quote-unquote lung cancer, and oftentimes it may have been mesothelioma. So it certainly is underestimated, but no matter how you look at it, even if we double the number of cancers from 3,000 to 6,000, that's still a very small number of cancers compared to 1.6 some million new cancers every year. So it's a rare cancer, but doesn't mean we shouldn't cure it.
Is there any, how many, patient is actually mesothelioma?
Well, I mean, you look worldwide, it's hard to know, because if you look at what's going on in some areas of the world, the United States, by the way, has not banned asbestos. So we still import. In fact, the imports of asbestos went up last year. So we have not banned asbestos, so it's still around. We're still using it. In my office, I have this nice little gasket that I bought down in the local hardware store. That was a third of it was asbestos. So you can buy it at your local garden shop, basically. So it's going to be around for a while. There are some countries like India and other places where people are using a ton of asbestos and they're not using any protection. And so worldwide, probably instances will go up for some time because there just aren't protections for people. And unfortunately, the United States just can't seem to get it, that we should have banned asbestos a long time ago, like about 70 other countries. But I guess now that Trump says that it's all a hoax, it's just fake news.
So maybe not rare cancer.
Huh?
Not rare cancer, maybe.
So it's not going to, it may not be a rare cancer for long. Who knows? In Australia and the UK are the places where the highest incidence per capita is partly because of the type of asbestos is so potent. So yes.
With new patients, what kind of barriers do you have, and what kind of barriers do the new patients report to you in getting them to your clinic for evaluation and treatment?
Well, I mean, there's technical issues. One of the things that I've been amazed at is that the U.S. government mandate to have electronic medical records has actually kind of backfired in many ways, in that we now, if we get a patient that comes in, they bring their medical records, and there's 1,500 pages of them instead of before, and there might have been 70. So now we have to look theoretically through 1,500 pages and find the little pieces of information that we need to find, and it's just really a bad system. So that's kind of a technical issue with finding the information. But in general, I think the problem that we actually noted and looked at in our numbers of people that come here is that in 2004, March of 2004, when the FDA approved cisplatin and pemetrexed, and then right after that, we saw a drop in our numbers for a while because now all the community oncologists can just treat mesothelioma. And so instead of still referring them to a center where there could be some kind of research program, there could be some kind of thought behind what you give, everybody and their mother could just give chemotherapy. I don't mean that disrespectful, but I should have counted the number of CDs I got from ASCO about and from Eli Lilly, about this is the new standard for mesothelioma patients is cisplatin pemetrexed. So if you get inundated with that, you guess what you're going to do instead of maybe thinking there are other things down the line. So then we started seeing people, on average, our new patient visits were about 9 months after their initial symptom onset. So we were kind of already down towards the end of the road.
Just to add to your comment, your question of the barriers is also insurance as well. Especially our Kaiser patient, they don't approve seeing Dr. Cameron for consultation because it's hard for them to get all that referral and authorizations.
Yeah, insurance in California in particular is a little bit difficult. There are lots of HMOs, and they basically see the literature is showing chemotherapy is the only treatment that's been shown in randomized trials, so they kind of drag their feet on everything else. Even chemotherapy, they'll drag their feet forever. There's some personal biases that we see from oncologists and surgeons elsewhere. They say that nothing can be done, and that's what people are told. Instead of at least, you know, being realistic and say, listen, there's nothing that I know of right here, but maybe you can find a research center that can help you be treated with some kind of new therapies and stuff like that. And then going through some kind of process to find those recommendations for your patient. There's only one oncologist that I know in West LA who, well, no matter what the diagnosis is, he'll research it, he'll find somebody within the world, call him up and find out what the best treatment is, and he'll tell his patient that's what you should do. Or that's where you should go. And, you know, I think pretty much everybody should be like him. And if you find somebody that has a rare disease, instead of just saying, well, I don't know, there's nothing I know of to do, you can go find something where they can do. And it's, unfortunately, time is always an issue. If you're seeing patients every 15 minutes, it's hard to take out an extra 10 minutes to do some research to figure that out. Anybody else have anything to add about the access issue?
Two questions. One of the audience, how many of you are either meso patients or a relative of a meso patient? Okay. Okay. And the question I have for you, Dr. Cameron, is, and I missed that this morning, was in this whole decortication process.
Yes.
Have I got that right?
Yes.
You have to make a decision at what point to do that. How? This is a two-part question. One, how do you measure? And two, how do you determine what point it's worthwhile doing a decortication?
That's about a whole nother day talk.
Okay, I'll let you go then.
It's, you know, it's a complex question. There are no real answers to that. There's a lot of opinion, and you know, some people, like I said, don't believe in doing surgery at all. And, you know, hopefully the Mars 2 trial will help kind of tease some of that out, although I don't necessarily totally agree with the protocol they came up with as a way to do that. But, you know, they hopefully will at least give us some indication of whether surgery is beneficial, at least in that context. So it's a difficult question. Nobody has the right answer, and we're going to still work on it and try and figure it out. Yes?
I wonder if you could comment on how much, because of the minimal amount of people who have mesothelioma, should the care and maybe the clinical trials and experimental trials, could it be or is it centralized? Is it feasible to say, okay, we're going to have 2 mesothelioma centers in the country and all the patients are going to go to those 2 centers? So we actually have decent clinical trials with enough patients. Is that a feasible idea?
I think it is when you have a universal healthcare system, and there isn't necessarily, you know, an impetus for every center to do your own thing. In the U.S., there's incredible reluctance on physicians, even in the smallest community hospitals, to send somebody out because they want to keep the patient care there. That's how they make their money. You know, that's how we all make our money. So you have to take care of patients, so they don't usually want to send them out. And one of the other faculty emeritus professors at UCLA always likes to tell a story about when he happened to be in independent practice down in the South Bay from here, just a little ways from here, and he saw a patient that had a really difficult problem, and he wanted to send that patient to UCLA, where he was also a professor, but he wanted to send the patient to UCLA, and the local physician said, oh no, you got to take care of the patient here. So there's a lot of resistance to sending people out. In other places like in Canada, I was there for a number of months when I trained in Toronto, and, you know, in Toronto there were only 2 hospitals that did thoracic surgery, so there wasn't a lot of fighting about, oh, I want to do it at my place, I want to do it at my place. There was just Sinai and Toronto General. So basically, you know, there wasn't a lot of fighting over the rare things like tracheal stenosis and mesothelioma and lung transplants. Those were all just basically done there, and other places wouldn't do them. In New York, there's a system of certificate of needs for centers that want to do transplantation. So you can't just start up your own transplantation program. You can't just start doing lung transplant. You have to get a certificate of need from the state government in order to do that. So I think that's not a bad system. If you can show there's a need, then sure, you can start up a program, but you can't just do it because you want to. So that might be a reasonable thing to do, but it's, you know, the regulation of the healthcare industry in the U.S. is not looked on favorably, particularly by the current government. So I don't think that's going to happen. But in other countries, I don't know. In Australia, I don't think people fight over seeing mesothelioma patients, do they? Yep. Yeah.
And there are not enough oncologists to go around, so people in the private sector are perfectly happy looking after colon cancer and lung cancer and breast cancer, so happy to refer on people with rarer cancers to centres of excellence. You know, it's going to be completely different in Europe again, presumably.
Yeah. It's, you know, it's just, unfortunately, it's just a system. It's hard to change the system, and there's all kinds of reasons for people wanting to keep people close to home. But the right thing would be to have centers. Now, it's interesting. Within the VA system, where I also have a practice, there's basically 2 centers in the country that do mesothelioma, and it's Boston and LA here. So we're the only 2 centers that have a designation of center of excellence within the VA system. Despite that, we can't get physicians from other VAs to just put in a consult. It doesn't cost them a thing to put in a consult. We are contacted by patients. We have to call the physician and say, can you please put in a consult so that patient can come and see us? And they basically won't do it. I don't understand that. There's no financial benefit. There's nothing. It is they don't want to do it. So I have no idea what goes on in the minds of people who just don't want to refer somebody to a place where they want to go and can take care of them. It's hard to know. Any other comments? Thanks for everybody for coming.